What is regenerative medicine and how does it pertain to skin science? And does it differ between what we think here in America and across the pond? To find out, stay tuned and we'll answer those questions.
This is the Skin Science Podcast. I'm Dr. Thomas Hitchcock, and here we'll investigate everything skin science and dissect it from a scientific perspective, analyze it from a medical perspective, critique it from a consumer perspective, and give insight from an industry perspective.
Hello, everyone. I'm Dr. Thomas Hitchcock, and welcome back to the Skin Science Podcast. And in the studio today, I don't have anybody. I'm just kidding. Angela is actually on a business trip. And so we do have our producers in the back here. We have Dr. Abigail Watterson. How are you doing, Abigail? I'm great. We have Seti and we have Alan. How are you guys doing?
Doing great. How about you?
Good. You were just in Russia winning awards for your film
Flip Turn.
Flip Turn.
Yes.
Yeah, won a couple of awards.
Yes, I won Audience Choice and Best Screenplay in International Russia within the Family Film Festival. And a couple of weeks before that one, I was in Slovenia in International Sport Film Festival, and I won that one as well too.
And can they watch Flip Turn anywhere?
On Amazon.
Yep.
You can just search on Amazon, Flip Turn.
And it is a family film, I believe, right?
Yes.
So it's appropriate for all viewers. So check that out if you have some free time. We have some very special guests. One is starting to become a friend of the podcast, meaning she has frequented several times, as Dr. Jigna Patel. How are you doing, Jigna?
I'm good. Thank you for having me back once again.
And then we have a new guest here, Ansar Mahmood, Dr. Ansar Mahmood. How are you doing, Ansar?
I'm good, Tom, and Jigna. Thanks for having me on for the first time.
Yeah, and so I was introduced to Dr. Mahmood from Jigna. Jigna thinks quite highly of him. So let me really quickly read a bio for each of them, and then Jigna, maybe you can add on to what drew you to coordinate this. It was really your mastermind that coordinated this episode of the podcast. And so, Dr. Patel, if you don't remember, and forgive me, I'm a little hoarse. I've had a little health issue the last couple of weeks, so if I sound weird, that's why. But Dr. Jigna Patel of Vedaskin attained her undergraduate and medical degrees from King's College London School of Medicine, 2008. Leaving a career which began in pediatrics, she then transitioned into general practice in 2012 and is now a well-established senior female GP with a natural affinity for the fields of dermatology, child and mental health, and her interests in the aesthetics industry largely center on skin health, regenerative medicine, and the skin microbiome with an evolving approach that encompasses integrative holistic well-being and longevity. She has national and global speaker credentials with the industry and is currently evolving in her newfound podcast role, which I'm assuming she's talking about us.
Obviously.
And then Jigna was kind enough to write Dr. Mahmood's bio here, and so I'll read it from her voice because she wrote it as if I was living in London. But Dr. Ansar Mahmood is a consultant trauma and orthopedic surgeon specializing in orthobiologics and regenerative medicine in Birmingham, UK. Amongst many of his accolades, he is the founder of the Academy of Regenerative Medicine and one of the few on our continent, meaning their continent, to hold a diploma from the American Board of Regenerative Medicine. He will soon be hosting the first British Regenerative Medicine Conference here in London, and he is keen to explore the holobiont philosophy and connections of the gut-brain-skin axis on today's episode. Welcome, the two of you. I'm very excited. We had a lovely conversation a few weeks back about this topic, and one of the first things that I always do with the podcast is talk about the fact that when we talk about science, it's a puzzle. It's not always very cut and dry. And I'm an avid puzzler for that reason. And so the way that I burn off steam is I go home and this is the puzzle that I brought today. I'm not sure if it's going to show up very well. It's kind of bright in here, but this is one that was actually built in the UK. So this is from a guy named Martin Rainsford, and he sent this to me. I've solved a couple of his other puzzles, and he sent me this one out of the kindness of his heart. And it's one where you got to use your brain. So this isn't a puzzle like a jigsaw puzzle. This is one where you have to actually find like the meaning of these symbols, cryptography. I'm being told by Alan to this camera, right? Cryptography, you got to like figure out the meaning of this. And then there's little things you have to do to figure out how to open it up. It's one of the ones where it's funny because you talk about blowing off steam, yet this is going to take a lot of brain power to figure out. But I actually quite enjoy that, the challenge of that. And so, you can actually pick this up. You can buy these. These are not very expensive. If you like a brain challenge puzzle, his are the ones to buy. His puzzle called Loki's Box of Tricks almost broke me. It was so difficult. But this is called Dislocation, and it's from don'teatpuzzles.com. Just one word, don'teatpuzzles.com, which is pretty straightforward. You shouldn't eat puzzles. Okay, so today's topic, regenerative medicine, and what does that mean when we're talking about skin science? Holistically as well. But when it comes to skin, why is regenerative medicine even something that we're going to talk about today? So I'm going to open it up to let Jigna first talk about why she corralled us together today and why she thought this was a good topic. And then we'll let Dr. Mahmood kind of fill in his kind of what his thoughts are on the topic and why he's so eager about this topic. So go ahead, Dr. Patel.
Okay, so first of all, I think just to keep this simple, somehow we found a common ground. I think we all appreciate science and we realize that there is a lot of stuff out there and a lot of procedures and treatments, whether it's in the aesthetic, medical world, orthopedic, regenerative world, which are coming out and being churned out at phenomenal speed with either questionable data or solid data or no data whatsoever. Mm-hmm. And just to expand on that, how I met Dr. Mahmood is actually through a separate company using supplementation. And I soon realized that we think the same about certain ways of taking care of ourselves, especially when it comes to the regenerative longevity aspect. And I know from our conversations that we've had when I introduced the two of you, we just seem to see the real picture, which is that everything is so complicated. Everybody is unique and balancing is the key. Overdoing isn't productive, and perhaps we are missing key elements when we're looking at how we manage our patients and perhaps how we've been trained. So I think that's why I find Ansar really interesting because, sorry, Ansar, I'm just going to say it, as a surgeon, it's not very common to come across people who have broad thinking. So it's a compliment, Ansar. But yeah, I thought this would be fun to do and actually to tie us all together and come from this at different angles is quite different.
No, I think this is beautiful. We actually internally, we have different type of doctors that make up my team, and we are constantly talking about, who's better, MDs, PhDs, and, of course we rib each other. And at the end of the day, what you just said is exactly the correct thing, which is coming at it from different angles because each discipline is trained to look at these things from a different angle. And to be completely, I don't want to say holistic, but to be completely thorough in the way that we research things, you have to look at things from different angles. You can do something scientific and look good in a petri dish, but it's like you just sent me a paper yesterday, Jigna, and you made a comment of this is in mouse, but it's an interesting concept, and that's the correct way of thinking, which is mice can give you a suggestion of what might be possible, but it's not. A lot of people interpret it as what is probable, which is absolutely not true. And then people go out and buy these supplements and take these supplements thinking it's going to make them live forever, when in reality, these were mice and they were it was a suggestive study, not something that showed direct correlation as to what would happen in long-term human type studies. And so Ansar, what's your thoughts on when it comes to, of course, this is a skin science podcast, you're more broad in the application that you would use regenerative medicine for. But when you're thinking of regenerative medicine, how do you define that? Like, what are the guardrails you put around that definition?
It's thanks, Tom. It's a broad term, and I think in the simplest definition I've sort of seen of it is where rather than, as doctors, we see disease as our puzzle, and we need a solution to that puzzle. But we often just treat the symptoms. And where regenerative medicine comes in is where we've got the potential to manipulate cells or change the physiological environment to actually turn back the clock or turn something on or off, which allows you to actually reverse the disease or eliminate the disease. And that's the promise. It's a huge promise. It's rarely been delivered, actually, even within regenerative medicine. But it's an area that is growing rapidly, and there's a huge amount of investment and research and development globally. And so at some point, this is going to reach critical mass. In certain elements of regenerative medicine, it already has, where it's shifted the balance of the way we treat certain conditions and diseases very differently. And I see the future of this space being identifying disease early and turning it off, or identifying it early and modifying its path. And that's where regenerative medicine really has its most potent potential. And that's what we want to see. And I'm an orthopedic surgeon, right? So even among surgeons, there's banter that orthopedic surgeons are the jocks of the of the surgical space. So we fix most things with hammers, chisels, and power tools. So I'm a little bit unusual because I've been doing aesthetics and dealing with skin wounds and burns for a number of years, and actually have been in aesthetic practice since 2006. So quite a long experience. And what got me interested in regenerating skin as well as other areas of the body was that I was in the game being taught what to use, the science or pseudoscience behind it of dermal fillers, toxins, skin modifiers, and superficially, most of it makes sense. And it's only when you then start to look at studies looking at what actually happens to the skin over time, the inflammation, the sclerosis, the combined trauma that happens to the skin over time. And then I saw my own patients returning to my clinic that I treated for 5 or 10 years with shiny, hard, sclerosed skin. And I thought, well, I actually did that to you.
Oh, geez.
And now what can I do to reverse that? Or can I do anything? And that's what got me started on my journey of platelet plasma and PRP and other modalities to try and reverse that pathology that I'd created. And it stemmed from that. And within orthopedics and many other areas, regenerative medicine and PRP and blood plasmas, stem cells, growth factors have been used for a number of years now to try and reverse disease. We haven't worked out how to do that precisely, but we can certainly modify its course and we can reduce inflammation. And we have the ability to try and stimulate skin in a way that is completely natural, so that it lays down the right collagen pathways with the right balance that nature designed, if you like. It's a way our skin was designed, without assaulting it with abnormal collagen or products that generate collagen, yes, but generate it in the wrong proportions. So you end up with more scar collagen and less natural collagen, which is where the shininess and the hardness and the change in the skin comes from over time. Right. So that's my journey to this podcast.
Oh, I mean, that's quite a journey. And it's funny because I remember the first time I observed orthopedic surgery. You are not kidding that you use hammers. And I mean, it's pretty brutal. I mean, they're like whacking things into the bones and such. And so it's not, you're not, hyperbolic when you say that. You're being very serious. The people that listen to this podcast probably aren't as familiar with orthopedics as they are with dermatology. But let me, I had Dr. Watterson, I asked her to come up with some, or to look up some definitions of regenerative medicine, because depending on who you ask, they kind of will call something regenerative medicine. And I want to find out from the two of you your thoughts on some of the stuff we do, especially in aesthetics, and whether or not they truly fall under regenerative medicine, and kind of what, like you said, Dr. Mahmood, is sometimes we use kind of like a hammer for everything, and we have a more is better type of mentality, and that can lead to results that don't look natural, or things that are deleterious. And it's not that the tool was bad. It was that we used it in a possibly incorrect way. And we talked about that last time, Jigna, with retinoids, is that retinoids are not bad. Your body needs retinoids to function. It's about using them properly when we have more information, making sure that we use that information to adjust the way that we use these tools. So the Association for Advancement of Blood and Biotherapies defines regenerative medicine as the process of replacing or regenerating human cells, tissues, or organs to restore or establish normal function. The Mayo Clinic defines it as focusing on developing and applying new treatments to heal tissues and organs and restore function lost due to aging, disease, damage, or defects. The U.S. FDA, regenerative medicine therapies are defined in Section 506G8 of the Cosmetic Act as including cell therapies, therapeutic tissue engineering products, human cell and tissue products, and combination products using any such therapies and products. And then she put a quote here from the Principles of Tissue Engineering. It's a book saying that regenerative medicine is not just the future hope, it is a reality today. Now, those are some differences in the way that they're being defined. And the major one I saw from the first two was, one was talking about the process of replacing actual tissues or actual cells, and then the second one from the Mayo Clinic's more about kind of like what Ansar was saying about basically a therapy in which tissues are modified, or which cells are modified, or disease states change by modifying those tissues and such. And so I don't know whether or not there's a hard and fast kind of like definition that says one is right and one is wrong. But in aesthetic medicine, for instance, you mentioned dermal fillers. There are some types of fillers that actually, although the marketing is that it creates collagen, is essentially what it is happening is it's causing scar tissue formation. And so the question would be, would you consider that regenerative, or would you not consider that regenerative? Because it is modifying, but it's not modifying in a way that the body would typically have that tissue. Does that make sense?
It does. And I think for me, Thomas, the key there, actually, all those definitions talk about function. Mm-hmm. And that's the crux of this. You want a tissue or an organ to return to normal function, whatever normal function is, how we measure it. And for skin, we know what the normal function is. And that normal function is produced by the right balance of the different tissues, right balance of the right collagens. And certain treatments, like the ones you've mentioned, disturb that balance and alter it. And over time, that accumulates and creates an imbalance, which is where the problem arises, of hard skin, shiny skin, skin that's not retaining its normal balance and elasticity, movement, etc. And that then compromises the barrier and the true function of the skin. And I think, to me, something is regenerative when it tries to retain or return to normal function.
Right.
And so I think function is almost laid out there as, well, that's what we're trying to get to. But actually, to me, you build the entire process around the function. So to me, all regenerative treatments should be aiming towards normalizing the tissue or normalizing the function of that individual or that organ or that part of the person that you're treating. You're trying to get them back to normal. These aren't super serums or super cells. They don't make you bigger, stronger, and see better, but they should make you normal. And it's normality that we're aiming for. And when you look at aging as a disease process, it's chronic inflammation over time, which creates cumulative damage. And so if you can normalize those tissues and put them back in a less disease, less inflamed state, then yes, you can start to reverse aging potentially. And I think that's that's one of the interesting parts of this. And I think, when I speak to patients, I normally put the functional bit right in the middle of it, and I build my consultation around it, saying, well, you've got an abnormally functioning knee, an abnormally functioning wound or skin barrier, and this is the problem, and these are the potential solutions, and this is what regenerative medicine has to offer, and some of it is experimental and new, and this is the more traditional things, and this is what's available with these devices or machines, and we try and build a solution, and the patient can then choose the bit that fits what they want. And what I found in my practice, I think if you give them all that information, generally most patients would naturally drift towards, well, I want normal function and I want regeneration, rather than, oh, actually, you're going to do something that makes me look good for a few years and then causes me harm over time.
Right, but that requires that the physician giving that advice understands what normal function is, correct? And my question to both of you is are there some areas within where you practice where the status quo or the standard of care makes us believe that there's possibility that we don't quite understand what normal balanced function is, so we're misleading our patients to go in a way that may not be what you just described?
Jigna, do you want to take that?
I will say yeah. I will say yeah. Now I'll just come at it from a psychological perspective, because I think this is where we have to kind of look at how the industry puts out the kind of the feeling around regenerative treatments. So bearing in mind that it's been put out to all sorts of age groups, all sorts of backgrounds, all sorts of purposes. And I think we'll probably agree that whenever anyone hears about regenerating collagen and boosting collagen as part of a regenerative treatment, it's a wild west, isn't it? And people who don't understand, who might require that type of approach, can be let loose with it. And especially certain parts of London. In fact, the UK is unregulated, let's be frank. We've got all sorts of people doing these treatments. And I've said this before, that there are a lot of people having treatments who don't need them. And especially in their younger years, where we're not so much concerned about function of cells, especially if you're from a healthy background or have no major chronic issues, and we're not looking to, well, we can't stop aging, it's going to happen. But we have people misusing treatments, and exactly what you've been saying, Ansar, ultimately, we're probably going to see, and I know we have already, lots of the current generations ending up with problems in the future, because there has been this constant drive to have more and more and more, perhaps non-invasive regenerative treatments, for instance, microneedling and various others, without really thinking about whether it's implicated. So that's number one. Number two, I think the intention to get someone back to normal function is correct. I totally agree with the approach there. But also we have to look at what's happening with the patient. So if we have a diseased patient or a chronically inflamed patient, and all you're doing is sticking on something or going from the outside and not addressing the whole patient, you're not really going to make tremendous difference, because the chronic insults are still there from internal. So I think sometimes people can bank too much on the term regenerative, not really understanding that there's more to it than that. And part of the reason for that is marketing and the way things are sold. So it can be deceptive, but in the right hands with the right mindset, it is a joy to use it as a method.
Yeah, it all comes down to, again, understanding what the central issue is for the reason why you're trying to do something that is regenerative, right? So if you don't understand the central the rationale, so for instance, I always use this analogy of if somebody is clinically obese and, they want to become healthy because they're starting to have cardiovascular issues or whatever, you don't say, okay, well, you know what, there's this great supplement that you can drink every morning that's really good for your metabolism, so just add that onto your diet. No, you're going to say, stop eating what you eat, and let's get a dietitian in here and give you a healthy diet that you should follow. And here's some exercises that you should do. You should move as much as possible. You're going to give them a whole reset, because you're trying to find the central issue is not, I need another supplement. The central issue is I'm doing things wrong. Something is wrong with the way that I live my life. I actually did my postdoctorate in tissue engineering, and so it was fascinating to me because we were growing literally organs in these bioreactors. And the reason why I kind of fell out of love with it is not because it's not fascinating, because it is. It's because I started to realize that you can make a perfect organ, but if you put it back into a diseased individual, that organ will eventually become diseased as well if it's a systemic disease. You have to address the central reason why that person is diseased in the first place. Sometimes that may address it, sometimes it may not. But leading that kind of what we're kind of leading up to is, one of my fascinations is, and you're probably not going to be shocked to hear this, is with the skin biome, because a lot of people, when they think of, there's a lot of marketing to the microbiome, and I don't like to even think of it that way because people think of the microbiome as like this separate entity, where I think of it as part of our physiology. I think of the microbes that that reside in our body. They're actually key players in how our physiology works, and not just our skin, but the whole set of things from brain to skin to our gut because you have to remember that these microbes are not just sitting there. They are spitting things out. They're eating things and spitting things out. So the nutrients that we take in, they're taking them in too. But they're putting things out that we normally wouldn't have in our circulation if they weren't there. And an analogy I give to people that don't quite grasp what I mean there is like when you drink a wine, do you think that the alcohol in that wine came from the grapes that made the wine? No, it came from the wine or the grapes being subjected to a microorganism that ingested the sugars of the wine and then turned it to alcohol. And so when you eat something, that same thing is happening inside of your body. The microbes are taking in nutrients and spitting separate things out. And those things are not necessarily inert. They actually do cause structure and function differences. And on the skin, it's the same thing. The microbes are not just sitting there statically. When you put 15 different things on your skin, that can have a huge impact on the way that they function, what they secrete, what they intake, what populations can grow, which populations can't grow. And just like we talked about in the definitions, is that when you talk about normative function of a tissue, I think of it as, and I think you said the word balance. Balance is very important, but the thing is, do we understand what balance means, especially with something like the skin biome? To achieve balance, first you have to understand what balance would be. And that's where I think in regenerative medicine, and I'll pose this question to the two of you again, but then also focusing more on dermatological applications or aesthetic applications, do we as a group, as a discipline, do we understand what the balance should be so that we can actually achieve it?
Thomas, it's a great question. The simple answer is no, because that will be individual. And so I think what we're learning is pattern recognition, like many other things. We're seeing that people, and it changes as you age, it changes where you live and what your diet is. So all these things influence, and there's been a lot published in the last 20 years on the gut microbiome, which I think is a good surrogate. What affects it, what changes it, the chemicals and their influence then subsequently on inflammation through your whole body. And I think things like, I don't want to promote anybody commercially, but things like Zoe, that's been all over the internet. It's been a great commercial success. But it's been talking about what gut health and its influence on the whole of your body. But we do microbiome testing in clinic, and one of the questions I always ask the labs that we send this to is that if you give me a whole bunch of bacteria and their quantities, what does that mean for that individual? And unless it means something that I can change, modify, alter, advise them to do something better, it's actually a useless test. There's no point knowing what your microbiota are and their balances if you can't alter them or you don't know how to alter them. So it has to be a useful test. As a doctor who sees patients, I need a solution, as I said, to the puzzle that's posed in front of you. And I think we're starting to understand that much better. We're starting to understand the influence that microbiome has on disease, whether it's neurodegenerative, Alzheimer's, dementia. All of these things are now being studied more intensely, and there are strong associations between certain diseases and gut health. But I think we need to understand it better, to understand how to manipulate it. But what we do know is that when we attempt to manipulate it, we can change it very quickly. So I do regenerative medicine, and occasionally I see patients who have got bowel problems, health problems. They're obviously got a metabolic syndrome. They are overweight. They are struggling to lose weight. They've got hallmarks of insulin resistance. And we see all of that. We can measure it on blood tests and body analysis. But then what do you do about it? And so we've actually done analyses where we can change their nutrition for as little as 2 weeks. And when we then bring them back, we find that their blood plasma has improved. The quality is improved. Their stem cells have improved. Their stem cell function has improved, and viability improves. So that's now been studied and shown to be modifiable in a shorter time as 2 weeks. So we now put patients on particular diets, low inflammatory diets, avoid certain foods. And we now have genomics that we can do to show what patients can absorb well and can't absorb well. So it becomes an individual puzzle. And, the aim, I suppose, where we're trying to head to in the future, in my practice, but I think globally in regenerative medicine, is somewhat personalized medicine. That's what we have to get precise, and we have to have a solution for the individual in front of us, which presents our own puzzle, a bit like the box you showed earlier. You've got to put lots of bits together, and the more information we're gathering, the more we're learning. But it's always a learning curve. I don't have the first thing I say to patients is, this is what we know, this is what we don't know. and the more you learn, the more you realize how little you know. And so we're treating you with the best that we have available to us at the moment. And that will change, especially when you're in the research space like we are. Perhaps every 6 or 12 months, you'll be adapting your protocols, you'll be changing. But as long as you're moving forward overall, I think that's the best we can achieve. I don't think we have all the answers around, what is the right thing for every single individual. But we're starting to get pattern recognition. We're starting to see, well, if we do this, we're seeing 80% of patients improving in this direction, in the direction we want them to go, in the direction they want to be. And those patterns are what's important. And, we're hoping that, I work with a group at the University of Birmingham that studies AI and machine learning. And so we're passionate about big data. And I think big data is what's ultimately going to probably give us a lot of these answers with rather than randomized controlled trials and studies, because they're too slow, they're too expensive, and they take too long to deliver outcomes that change medicine. Whereas big data is much more likely to achieve that in a shorter space of time.
Yeah, so I'll push back slightly on that, because I agree. I'm not the biggest fan of AI and such, not because I don't think it has potential applications. It obviously does. It's because in the field of science and medicine, you can only get out of it what you program into it, right? Because you have to feed these algorithms and such information in order. And the problem with some of the even the current knowledge when it comes to especially the skin biome and such is that if you look at the last 50 years of research, they've drawn conclusions based off studying 1, maybe 2 pathogenic strains of certain microorganisms. And now we're finding out that there's hundreds, if not thousands, of different strains that can have huge implications as to how they affect the health of the individual. And so, in order for us to truly program, like you said, big data, we have to really delve into doing the wet research in order to decide or to determine what are the implications of those strains and human health. One that I've become very acutely attuned to is C. acnes because, I've studied that for the last 10 years and we've seen huge implications as to, the ones that have been studied for 50, 60 years were pretty much determined that it's a pathogen as a species, where the research that we've done in other groups as well recently has shown that certain strains are not only non-pathogenic, they're actually symbiotic in nature and required for skin health. And so I do think that we have to be careful about the AI thing because it's junk in, junk out, treasure in, treasure out.
And that's why we haven't had AI deliver anything substantial in medicine yet.
Right.
Because it's not as though AI is new. Everyone got very excited when ChatGPT came out, but we've been playing with AI models. And just for clarity, it's a slight bugbear of mine because remember, we don't have any such thing as AI. There is no AI in the world. It's machine learning.
Right.
There are machines that we train on a model, as you say, and junk in, junk out. And that's exactly the issue, that we currently don't have the models and the algorithms. But what I'm confident of is that they are growing. The models are getting bigger. The understanding is getting bigger. So we're starting now to put in more robust data. And we're a long way from actually achieving anything substantial, I think, in healthcare from machine learning or AI, as everybody calls it. But, we don't have any true artificial intelligence in that, something that thinks for itself.
Right.
That's the traditional model. Yeah, that's what AI actually means. So it thinks for itself and independently reaches a conclusion. That doesn't exist yet. So machine learning models are what we're talking about. And as you say, all of the healthcare we've put in. 10 years ago, I listened to a cardiology professor telling us that in 5 or 10 years' time, they'd have sorted out who was going to die from heart attacks, who was going to need CABG and coronary grafts. And they've tried that model because you've got countries that have got massive data sets,
right?
Hundreds of thousands of patients a year being inputted in. But if you put them in with the wrong potential predictive outcomes or the wrong information, they just produce junk. And up till now, they've just produced junk.
Right. There are some. I see what you're saying though. As far as there are, the predictive natures are going to get better when we have better input to put in there. Interestingly, my very first, I don't use Chat GPT at all, but my friend was talking it up, and I had just put out my book, and so he said, here, it'll write you a bio or something, and so he said, what is rebooting the biome or whatever, and it basically said that I was a New York Times best-selling author. I was like, I'm not. And I'm like, well, it's very kind of AI to think so highly of me, but that's a big lie, So again, that's why I'm saying, it's one of those things where it's like, it's still got a lot of kinks. But let me just bring us back onto the course of regenerative medicine. I do think, as what Jigna was alluding to, is that there's a bit of reductive, is the word reductivism, is that a word? There's a reductive nature in which to sell things, we basically take a very complicated process of biology and try to say, if you take this supplement, it will fix everything or make everything better. Hair supplements and all that stuff. It does happen, and we get it. That's the way the economy works. But the problem is with the skin biome, for instance, since that's the specialty of this podcast, there's a bit of kind of trend of they latch on to buzzwords and then try to monetize them. For instance, there's prebiotics, probiotics, and postbiotics. And Ansar, you actually touched on something that I thought was brilliant, because in the United States, a lot of people are focused on, well, what probiotics should I take to get my gut health in order? And a lot of what is in these probiotics isn't even viable anymore because they're sitting on store shelves for months and months and months. They're not regulated by the US FDA. I'm not sure how in the UK those things are regulated, but people are like, what should I take? And for me, there's a couple of companies that I think are a little bit more scientifically driven that I steer people to if they want those things. But you mentioned change their diet, which to me is way better than choosing, unless you know that they have a pathogenic microbe, like for instance, if they're getting ulcers and they have a certain strain of H. pylori that you need to get out of there and then repopulate with another H. pylori. That's one thing. But if it's, when you change their diet, you're changing a lot of things. You're changing the prebiotics that are going in and feeding those microbes. You're changing the environment of what's happening in there too. So if you have a diet rich in starches or sugars and refined foods, those are going to be fuel for certain microbes to just start changing the environment into a way that's going to change the makeup of the microbiome, change the way that the interaction between the biome and the GI tract happens. Same with the skin. Is that there's people that are saying, well, I put inulin in this and therefore it's a prebiotic. But the thing is, a prebiotic for what? If it is a prebiotic for all microorganisms, how is that going to bring balance back to your skin? If you don't think about the environment is almost just as important, if not more important, about what grows in any particular area versus sticking an organism there. So Jigna and I, we laughed a little bit about this review article that came out that showed that lactobacilli were more prevalent in people that had more aged looking skin. And yet lactobacilli are the number one thing that people are ingesting as probiotics, right? In dairy and then in probiotics and such. And so we're kind of like, well, whoops, does that mean we've caused people to look older than they are because of our push of this particular strain when we didn't quite understand it? And the answer is we don't know yet. We don't know what that means or the implications are of that review study. But the real question is, should we be focusing on more than just this is a good strain, this is a bad strain? Should it be more holistic, as you have to look at the whole environment? Is it the right environment? Does it have the right food source? Are there the right bacteria? And how do we convince people that that's the way to go, if that is indeed the way to go?
I think, Tom, that almost certainly is the way to go. But I think we need something convincing. Yeah, patients need simple advice. And what I'm finding is the world is just getting so complex. Everything's caught up. And I had a patient in clinic recently who'd read up. He's been listening to podcasts, maybe like ours, but many others. And he arrived in clinic on 28 different supplements.
Oh, geez.
Because
sounds like a famous certain individual, but we'll not name them.
And he said, well, which one of these, doctor, should I be taking? And I was like, I don't know, right? Because I no longer know. I know what's probably good for you. But I don't know if that thing, when taken with these other 25 things, is good for you any longer, because actually you can have cross-reactivity. And there is this sort of race, in simple terms, where people think, well, if something's good for you, if I take a lot of it, it must be even better. And we know that's not true, because the human organ we're biphasic creatures. If you've got thyroid disease, you don't just give someone as much thyroxine as possible to resolve that, because we know what happens. If you overdose them on something, there's a negative effect somewhere else. Something else shuts down or stops working. And in fact, your thyroid depresses itself because it thinks, I'm getting too much signal. I can't tolerate that signal. And in the same way as gut microbiome and skin microbiome, they're going to work in the same way. Occasionally, you may need to do a reset. And one of the dangers around I think gut microbiome in particular is that people sometimes get entrenched. You have to remember, if you've had bad microbiome for a long period of time, those bacteria are a bit like old World War II soldiers. They entrench. Yeah. They sit in trenches. They create an environment that's good for them, which may mean gut inflammation, which may mean, as we said, high pylori and ulcers in which they can live and burrow in. So how do you then resolve that in an easy way? And sometimes there isn't an easy way, and sometimes the only way is, and I've got colleagues who are advocating this, where they say, well, you can't get rid of those, they're entrenched. So what you've got to do is, rather than just trying to rebalance it, which takes far too long, and now the environment within the gut is now altered and has been altered for so many years that they're embedded, you've got to wipe it out. So they put people on antibiotics broad spectrum or metronidazole, and they think, let's just rebalance, let's just kill everything, and then we restart. And that's one way of looking at it. And I don't know if that's the right answer. I mean, it sounds a bit drastic to me, but they found that in some patients that has worked for them in the clinical environment. They've had patients where they've tried to probiotic and alter diets and it hasn't worked. And they've, something your listeners may or may not be aware of is that there are fecal transplants.
Yeah.
So so you can literally get paid to you can sell your shit for money, and people will buy it, and they will actually feed that shit to other patients, because actually healthy bacteria within that environment, in the most extreme cases where nothing else has worked, you can actually repopulate normal bacteria from another person's healthy bacteria, which generally comes from feces in their gut.
Yeah.
And we have a specialist at the University of Birmingham who's one of the national experts in this area, and one of our professors in gastroenterology. It's a fascinating space, and he knows more than almost anybody else about this area. And yet, when I ask him lots of questions about, what about this and that, he's like, well, we don't know. Because patients are such complex puzzles that we can't fix every single one, but we need patterns and we need ideas that allow us to progress their condition forward. And that's where I think where the difference is in research. I'm a researcher, and the first randomized controlled trial I delivered in the National Health Service in the UK took me a year or two to get set up, funded, running, and then took 4 or 5 years to deliver. And 7 years later, I was 7 years older before I got the answer to something that didn't answer anything. It just raised more questions, which meant I had to now do another 5 randomized controlled trials trying to find the answer. And that's where I realized that, RCTs, although they're great, level 1 studies are fantastic, and we're certainly not binning them. They're the best way of us getting trial data and comparing one intervention to another, or a placebo, control event. But they're not the answer. They're too expensive. They take too long to deliver. So we need alternative ways. And as long as we've got safe methods of treatment, we've got patients in front of us that we can't say, well, there's not a study in that area, so we're not going to treat you, and we don't know what to do, so we're not going to treat you. We actually have patients we actually have to do something for. In my world, I'm a traumatologist, so as I said, an orthopedic surgeon, and everything's binary. You either hit it with a hammer or you don't hit it with a hammer. And you've got to make a decision, right? You can't say, well, we're not doing anything for you.
Right.
Because there's a patient with a pathology and a problem, so what are you going to do for them? So you need a solution. And I think bringing those patterns together and trying to normalize, and that's what I aim for. Well, what's normal? And we know normal is a range. It's going to be a range. But one of my questions to you now is, as a microbiome of the skin expert, is that how do you? I mean, when you pick up P. acnes, and somebody's got aggressive acne as their problem, and it's severe, and they've tried drugs and other methods, and people put them on antibiotics, which we know has side effects and potential longer term harms. What is the solution to that? Is there a way that we can assess that person's microbiome and say, well, actually, your left shift or your right shift, we need you in the middle, we need you in this normal range? Can we do that practically at this stage?
Well, that's the thing is, I think we're not too far from that, but to take a step back and talk about your fecal transplants, actually there's a documentary called Designer Shit, and it follows a woman that has colitis pretty severely, and she decides to go on this journey of, because a lot of physicians won't do that, and no insurance will cover it unless it's for a specific indication. She decided to just take it into her own hands and get her fiance, and he donated his specimens, and she did it herself. And interestingly, if you watch it, it seemed to improve slightly, but then it kind of went back to baseline, and she got pregnant, and her pregnancy basically cured her colitis. And that's where I think, it enters into the next kind of facet of our discussion, which is, again, it's not so simple as introduce new bacteria, take away old bacteria, because there's a reason why we have the microbiota it was. It's not necessarily just the luck of the draw that when we were born in that room that we were born in, the bacteria fell on us or our parents gave it to us. The environment in which our bodies are, the things in which we do, the habits that we have, the houses in which we live, the states or countries in which we live, all that feeds into the environment that produces what grows in and on us. And then you have to take it a step further as to there is a genetic component to the way in which our bodies react to those microbiota. And so just like that woman, when she had a baby, there was something physiological that happened to her when she was pregnant that changed the way her immune system was reacting and causing that inflammation. And that's where, when it comes to things like acne, there's a lot that is connecting inflammation in the gut, the brain, the skin. And we know there's actually a paper that Dr. Watterson printed out, and I was glad I pointed her to it. I didn't know she'd find it, but she did. And there's actually this really cool, it's by Emmanuel Contasselt and Lars E. French. Basically, the title is Propionibacterium acnes strains differentially regulate the fate of Th17 responses in the skin. And we can try to put that in the link below when we put it on there. Thank you. But the reason I bring it up is because basically what it shows is that the strain of the microbiota does affect the naive CD4 positive cells in the immune system and tells them whether or not they need to be quiescent or inflammatory. And so, yes, the strain is indeed important, but the fact is that for certain strains to live, they have to have a proper environment, because the same investigators, not the same investigators, but the same time period. Let's see, this is by George W. Gack, another paper, Phenotype of Antimicrobial Activity of Th17 Cells Induced by Propionibacterium acnes Strain Associated with Healthy and Acneic Skin. Basically, their research showed that if you take C. acnes strains that are associated with healthy skin, like the ribotype 6, and you put them into a media with immune cells, and then you take ones associated with disease state, like RT1, certain strains of RT1, and you put those with immune cells, the health-associated strains actually will cause the immune cells to seek out and kill off the disease-associated strains, where the opposite isn't true, because the opposite, those disease-associated strains would cause the CD4 cells to become more inflammatory. So there is this crosstalk between the microbes in the skin and in the gut and the different strains and the human immune system. So the immune system is what is very important in the way the body decides, how do I react to these microbes? So understanding that, but also understanding, so for instance, most people or most dermatologists, and you guys can correct me if I'm wrong, but having talked to so many of them and even the key opinion leaders that look shocked when I would speak to them like this. But when I say, what if I was to tell you that C. acnes overgrowth has nothing to do with the development of acne, they would look at me like, what are you talking about? That's like a fundamental thing we're taught in school. And but we've done studies where we're putting literally billions of C. acnes onto the skin of individuals, both healthy as well as acneic skin, and nobody is getting more acne. And so, of course, we're putting health-associated strains. And so it opens up the door to say, well, do we truly understand what is causing the disease state in the first place? And so part of what the research we're doing at Crown is we have scientists that are looking at whether or not, are looking at the role of the C. acnes species. It's basically, and we don't have enough time because Dr. Watterson's saying we gotta quit in a few seconds or a few minutes. But it's, if you look at the C. acnes species, it's actually right in the middle of this wheel of balance within the skin. If you don't have enough C. acnes, you tend to have disease states like acne, rosacea, dermatitis, psoriasis. They're associated with less C. acnes. There's not any literature that I have found that shows that an overabundance of C. acnes leads to anything, because C. acnes is almost regulating, because it doesn't like oxygen. It likes to live in the hair follicle. So when it spills out onto the surface, it limits itself into how much it can spread. But interestingly, C. acnes actually keeps things from ingressing into the follicle, like Staphylococcus species and Malassezia furfur, which are things that are associated. If you look at studies that have looked at what lives in the follicles of acneic individuals, it is things like Staphylococcus species and Malassezia. And so keeping them out of the follicles is a central role of C. acnes. Additionally, C. acnes lowers the pH of skin, keeps the activity of proteases that are secreted by things like staph from being overactive and over-desquaming. And that's why when you look at people with atopic dermatitis with barrier issues, there's less C. acnes and way more Staphylococcus. And so we are starting to understand the balance that is there. And it's not just about the right species, but it's the right environment as well. Interestingly, the food source is not as important, because the body already provides that. So the body provides most of what is needed for these strains to grow. It's more along the line. It's more interesting about what you're doing to your skin that's causing, pH changes, or if you're overwashing, which is one of the biggest culprits. And so, naturally people think, if I have acne, I have dirtier skin or oilier skin, I need to wash more. That actually causes it to get worse. And so it's a matter of, do we truly understand, have we been doing things wrong because we've been saying C. acnes causes acne, when in actuality, my hypothesis is that C. acnes is actually a critical fulcrum to the healthy balance of the skin. And so it's very interesting. We're starting to find more information that we may need to adjust the way that we treat, because a central premise may be slightly skewed. I'm not sure if that was what you were asking or not.
Well, yeah, no, it's it's giving us a target, and it's giving us a solution potentially. So again, if we're treating patients, because you're absolutely right, this is what is, I think, the science now, and we're trying to. It's difficult to see the wood for the trees now, and there's so much information out there that people are getting lost, and there's so much pseudoscience, and there's so much crosstalk. That, as I said, to get patients in clinic now on 25 supplements or 18 supplements, because if they feel unwell or they've got a problem, they try to find their own solutions. And Dr. Google is powerful. Yeah. And they can read all the studies we've got, but only have partial understanding, because they are not scientists, they're not doctors, and they don't. And I'm saying I don't know. So if I don't know after 25 years of medicine, I don't expect a patient to read something and say, well, this worked in a mouse and it showed improvement in their skin or their recovery or their longevity. And there's a molecule, and some famous person is now taking that and saying they feel better every day. And that's enough to drive them to go and buy this stuff. And suddenly they're on that one, and then the next one, and the next one. And it's a difficult journey. And I really feel for some of my patients who have got autoimmune problems, for instance. Right. And the traditional medicine is failing them, and they are struggling. And so they're trying to work everything out for themselves, because they get see a doctor, the doctor changes their pill and says, I'll see you in 3 months or 6 months. And every day they're struggling. Yeah. So they're trying to find solutions, which is why they end up in this position of, supplement after supplement after supplement. And we're not, the healthcare space is what I mean by we're not necessarily helping them, because the doctors themselves are trained in one box, right? Think in one box, use the same textbooks when they graduate, and some of that knowledge we're now finding out rapidly is outdated or incorrect, but it was sold to us as this is the answer. We don't have an answer. Yeah, Jigna, we got to finish, but I wanted to end it with your thoughts on this, because I think that part of the problem is...
I feel quite strongly.
Yeah, but the part that he just mentioned, which is, they're on 25 supplements and they're willing to give it a go, to give more pills, more supplements. But what about change of habits, change of lifestyle, change of your environment? Because could that not be the answer to, changing what's causing these. I mean, it's well documented in the medical literature that people that live in rural areas that have dirtier jobs tend to have less immune issues, less inflammatory issues than people that are more affluent, that are more hermetically sealed in their homes. So why aren't we looking there?
I think it's because people aren't thinking outside of the box, are they? So, you know, we have to think about, I'll just throw in some interesting things. Up to 70% of people with autoimmune disease have some history of significant trauma in their past lives. So we have to think about what the implications are from a hormonal level. Yes, you're right. If we have been living in different environments, that will influence how we behave. I think it's taking accountability, right? So we can throw things at patients, put a Band-Aid on, provide a solution, but sometimes we have to get them to do the work. And I will say, because I know we're at short time, that there is now probably a big enough argument to push forward how we behave as individuals to help influence our immune system from a gut perspective and a skin perspective. Because the biggest issue in the skin industry is the stripping away, the over cleansing, the overuse of products, and the overdoing of treatments, which is disrupting our skin barrier, has a knock-on effect on our immune system. And interestingly, we'll probably see data, hopefully, in the coming years that it has a reverse effect on the gut. So it isn't easy. It is very, very individualized, but I think we do know enough to be able to help start influencing the commensals, what should be present, and trying to find strategies that actually respect which biome you're dealing with.
Absolutely, amen. And I am an atheist, but I will say I do hold to the adage of God made dirt and dirt don't hurt. You know, that's something we said when we were 5. But the thing is, I want to thank the both of you for having such a candid and useful discussion with me on this today. If people want to reach out to you and ask you more questions, where can they reach you guys, Dr. Mahmood?
Well, my Instagram handle,
sure,
which I'm trying to get good at actually monitoring and answering, is at Dr. Ansar Mahmood. So it's fairly easy to find Dr. Ansar Mahmood.
Okay,
there's only one of me.
Yep. And Jigna, we know where to find you, but just in case they didn't see the other podcast, where can they find you?
Yes, I'm on Instagram. I don't have time for anything else. And you'll find me at Vedaskin Clinic and also on the Skin Science podcast episodes.
Yeah. Yep. And you can find me at dr.t.hitchcock on Instagram. I try to get back to everybody, but I'm also not too great at it. But anyhow, if you want more information on this topic, or if you want to find out what more information on skin science as a whole, you can go to crownlaboratories.com, or you can follow Crown Laboratories on Instagram. And don't forget, if you're listening to this on Spotify or some other audio application, to favorite us so that you can make sure you're made aware when you have new episodes. If you're looking at us on YouTube, make sure you like and subscribe. Please even leave a comment if it's a nice one. No nasty comments. We want to continue and grow and let the algorithm give this to people that might be interested in this content as well. And so, as always, thank you for your time, for your eyes and your ears. We hope you learned something from today's conversation. And until next time, goodbye for now.